Welcome to an introduction to acute kidney injury, or AKI. This presentation will take us through what an AKI is, who's at risk, and how we initially manage our patient with an AKI at ESNEFT. This has been designed primarily for nursing staff. So let's start by understanding what an AKI is. So AKI is a sudden reduction in kidney function, and it just makes maintaining fluid balance, electrolyte and acid-base balance difficult. This normally happens as a complication of another illness. It's very common in hospitalised patients, so a lot of the emergency admissions coming into ESNEFT will have an AKI, so about 20% of those will have an AKI, and over 500,000 people in England sustain an AKI every year, so it's really prevalent. The presence of an AKI is usually determined by looking at the patient's serum creatinine levels and their urine output. So creatinine is a waste product of muscle metabolism, and it's usually filtered out by kidneys and excreted in our urine. So if our kidneys aren't functioning properly, then the creatinine builds up and the urine can reduce. So an AKI is staged either 1, 2 or 3 according to its severity, and it's usually staged by the doctor or the A&P. The assessing doctor should look at the patient's baseline serum creatinine and how much the creatinine has risen from its baseline. So usually for a healthy kidney, our creatinine sits around 50 to 98. A good marker to remember is that creatinine usually is less than 100. But just remember that for those patients with CKD, so chronic kidney disease, their baseline creatinine is likely to be higher, but they can still develop an AKI. So why am I telling you this? Why is it important that we are able to recognise those patients with an AKI? This is because they have an increased risk of dying. This is 10% for an uncomplicated AKI, but if there is multi-organ failure and dialysis, then their mortality risk is up to 80%. AKI is reversible, and patients' chances of survival are high if we recognise and treat it promptly. If we don't recognise the AKI and treat it effectively, this can increase the length of the hospital stay, and it can also lead to permanent damage of the kidney. So which of our patients are more at risk of developing an AKI? So everyone can, but those more at risk are those that are of an older age, those with CKD 4 or 5, diabetes, heart failure, liver disease, peripheral vascular disease, or any cognitive impairment. So these people should be closely monitored for their serum creatinine levels and their urine output. Also, certain risk events that could trigger an AKI. Anybody that's having surgery, anyone who is suffering from hypotension, hypovolemia, sepsis, having a contrast scan, or taking nephrotoxic drugs. So how as nursing staff do we recognise somebody with an AKI? So firstly, we need to closely monitor patients' urine output, particularly those people that are either at risk of an AKI or have one of the trigger events that we spoke about. So for example, an elderly person with heart failure and diabetes who is having surgery is more at risk of developing an AKI post-operatively than a younger person with no comorbidities. So if there is no urine output or a reduced urine output for more than 6 hours, this is where we need to be concerned and we need to act on this. So when we say a reduced urine output, we are expecting our patient to pass 0.5 mils per kilo per hour. So that would be technically half a patient's body weight. So if they weighed 80 kilograms, then we'd expect them to pass 40 mils of urine an hour. Or if they were 50 kilograms, we'd expect them to pass 25 mils an hour. So as mentioned, if they have no urine output or reduced urine output for more than 6 hours, our process is that we are first of all going to give them an opportunity to pass urine, take them to the toilet, give them a commode or a bottle. We are then, if they still haven't passed urine, going to perform a bladder scan. We're going to make sure we review their fluid charts, and if they have not got a fluid chart in place, we are going to start a 24-hour intake and output fluid chart. We're going to consider the need for catheterization, and we're then going to report any reduction in this urine output to the doctor. So your patient has been diagnosed with an AKI. What do you as nursing staff need to do next? Firstly, monitor your patient's news too according to the protocol. Make sure you're aware of how frequently you should be doing those observations and look for any signs of deterioration whilst they have this AKI and escalate if they're becoming worse. Often the cause of the AKI is pre-renal and the patient will need intravenous fluid, so you may be involved in giving fluid boluses, either 250 ml or 500 ml, given over 10 to 15 minutes. In order for the patient to have the AKI diagnosed, bloods will have been reviewed. However, they will need subsequent daily use and ease during their acute phase of their AKI, and this is one of the NICE guidelines. It will also be your responsibility to make sure the patient's had a urine analysis done. So the urine gets dipped and checks for proteins. If the proteins are positive, you will then need to send the urine off for a urine ACR or a urine PCR, and this can go to the lab in one of the 2 bottles that are on your screen now. When the time is appropriate, make sure you weigh your patient. Also be aware of any referrals that need to go off. So when you need to refer to nephrology, when the patient gets referred to urology. The doctors will do this, but it's good to have an idea. So this information can be found on the AKI bundle. Lastly, please keep an eye on your patient. Look for signs of improvement, but also be aware if the patient is getting worse. Is the urine output reducing even more? And do you need to report this? All of this gets documented on the AKI bundle paperwork. So this on your screen is the newest version of the AKI bundle that has just been put into the trust. Please note it is a yellow form, not white, that's displayed on the screen. There is a new place on the chart at the front to document urine analysis results and also to document bladder scan results. Please use this so we have a standardised place to document this important information. The front of the AKI bundle is for the doctor to complete their assessment of the patient, and then on the back there is a place for the RNs to document their interventions. So this is the back of the AKI bundle, and you can see the red arrow pointing to the section where it's the RN responsibilities. This is where you will mark off any interventions that you have completed. Also on the back of this chart is information for you about hyperkalemia management and also information of when to escalate and involve other teams. Before you complete your drug round, please make sure that any patients you are looking after that have been newly diagnosed with an AKI have had a drug review. This is just to ensure that the nephrotoxic drugs are reduced or temporarily stopped. So that brings us to the end of our presentation on an introduction to AKI. Thank you very much for your time, for listening and for watching. Hopefully, if we follow these guidelines and these processes within this presentation, then we can really improve AKI care within ESNEFT. 2 things to take away. Please remember to act on a reduced urine output and make sure we are starting the AKI bundle, getting that paperwork into the patient's notes that has an AKI. Thank you.